Good afternoon, and welcome to our first web-based seminar on best practices in TB control, the introduction to the TB Cohort Review Process. My name is Bill Bauer, and I'm the Director of Education and Training at the Charles P. Felton National TB Center, a component of the New Jersey Medical School Global Tuberculosis Institute. I will be moderating today's program. This is the first of a series of 3 webinars that will look at the cohort review process. Today's is the introduction. The objectives of the webinar today are these. You'll be learning the elements of the cohort review process so that you can lead your team in doing that. You'll learn the CDC guidance and how you can apply it regarding the cohort review process. You'll compare the cohort review experiences of TB programs in New York City, Missouri, and Oregon to identify the aspects of those that you can adapt for your own program. And then you'll discuss how to apply principles of continual quality improvement that are sort of the basis of the cohort review process so that you can manage the clinical services, contact investigations, and so forth in your program to eliminate tuberculosis. The faculty today are myself, Dawn Tuckey, the program consultant from the Field Services and Evaluation Branch in the Division of TB Elimination at CDC, Dr. Crispin Cambili, Assistant Commissioner of Health and Director of the Bureau of Tuberculosis Control, the New York City Department of Health and Mental Hygiene, Harvey L. Marks, Jr., he's the Chief of Disease Investigation Unit at the Bureau of Communicable Disease Control and Prevention, the Missouri Department of Health and Senior Services. And Heidi Boehm. She's the TB Controller of the State of Oregon Department of Health and Human Services. The agenda for today is, after the introduction, I'll provide an overview of the principles and processes of cohort reviews. I'll share with you some of the tools involved, how other programs are doing it, and place this in the context of what we'll be exploring in the future webinars on cohort review. Ms. Tuckey will present the recent CDC guidance regarding the cohort review process and what is expected of programs in 2010. Dr. Cambili will share a historical perspective of cohort reviews in New York City, highlighting the key components, benefits, and challenges in that work. Mr. Marks will share the experience in implementing cohort reviews in Missouri, and Ms. Boehm will share that of implementing cohort reviews in Oregon. And finally, we will have time for questions and discussion. Now, participating in this webinar, I know we have a really mixed audience. Some of you may be program managers, medical directors or consultants, epidemiologists, public health nurses, supervisors, case managers, outreach workers, or any of a number of health occupations that contribute to the effort to eliminate TB. I would like to get us all on the same page by going over the basic principles and processes of cohort reviews. So, if you Google TB Cohort Review, you only get as far as TB-COH, and then a link to this resource pops up. This is the Understanding the TB Cohort Review Process, produced in 2005 by CDC, and the video and DVD are still available. The guide is being updated. These are the basic source of what we'll be talking about today. And I wanted to start with a quote here. What is a cohort review? Well, in essence, it is a meeting. And the part of this definition that I want to highlight here is this part here. You've got a list of patients. You've got the people with first-hand knowledge of each patient, and you've got someone supervising and reviewing their work. That's what a cohort review is. This is from Dr. Frieden when he was the Commissioner of Health in New York City in charge of TB control, and of course now he's the Director of CDC. So I'll go over some definitions and the timing of cohort reviews here. In a meeting of a cohort review, you do a systematic review of the patients with TB disease and their contact. And it's important to remember that a cohort, in this case, is defined as a group of TB cases that were identified over a period of time. As we'll talk later, usually that's 3 months, so it's done quarterly, but there are different ways to do it. The cases are reviewed approximately 6 to 9 months after they are reported. So let me talk you through this. If cases are reported, say, are identified in January, February, and March, then you're going to leave 6 months. April, May, June, July, August, September. You leave those to do the work on those cases, and then you would be doing your cohort review sometime, say, in October, November. That's the timing that's important to bear in mind. And because many of the patients will have completed or they're nearing treatment completion, you may still have time to be able to take action to make sure that they complete treatment before the time is up. Now, when we talk about how the meeting goes, in fact, the cases are reviewed in a group setting. In this group setting, there's information that is presented on each case by the case manager, and it falls into these categories: demographic information, the clinical lab and radiology information related to the diagnosis of TB, and then the treatment information, the regimen, adherence, completion, and how that was managed. And lastly, the results of contact investigation. So during the meeting, you're assessing these individual outcomes, but that sort of adds up to a picture of the program as a whole, and you're able to assess group outcomes also during the meeting. Different indicators are used, and what's good is that it's a chance for you to track your progress towards national, state, and local objectives. Everyone leaves the meeting knowing the results. And the meeting can be done in a number of ways. In person is often more common in a city health department, or by teleconference in a state program. Now I want to say something about the participants in the cohort review. The people who pretty much are the real key leaders in a cohort review are the program manager, the medical reviewer, and the data analyst or epidemiologist. But the largest number of people who will be participating will be the case managers. Okay? Case managers will be presenting their cases to these people up here. The supervisor, I think I would have drawn this with the supervisor on the side, because the supervisor intervenes and supports the case managers, but is not really a bypass through whom things are presented. And in fact, the case manager will have information from outreach staff, DOT staff, community providers. I've seen it be social workers, shelters, any other place that has been involved in the care and treatment or the contact investigation. That information will be presented by the case manager to the leaders of the program, and they'll give feedback. Now, I said before that cohort review was a meeting, but in fact, it's the entire process of preparation for this meeting, presenting and feedback during the meeting, and following it up afterwards that makes this management intervention really work to improve programs. So I'm going to go through each of these steps now and remind you that some of these will be explored in more detail in our upcoming webinars. First of all, in the preparation phase, the first point is that all staff must know your national and your local objectives. And I know that many programs are also incorporating their NTIP indicators into the cohort review process. That's an innovation which is really exciting to see. Second point is every case of TB must be assigned to a case manager so that all of your systems of case management, case review meetings, supervision, all of that is in place and working to do the work of TB control. The third point is that the TB registry is your basic platform. That's where you get your list of patients, and you can send that list out 3 months before a cohort review meeting so people know which patients are the ones that they will expect to report on. Then, through the normal case management review processes, your staff will be prepared to successfully present the outcomes of the cases and contact investigations. Some programs do actually include sort of a practice session to practice presentation skills. Now, one of the things that makes the presentation of many cases in a meeting possible is to have sort of a standardized, concise form that requires only the most important information, and you get the same information on each patient. There's a wiki that is being set up at the Program Evaluation Network Tools Committee, and here's the site. And it will have many examples. The form that I'm showing right here is the sample one that is in that booklet, Understanding the TB Cohort Review Process. In giving a standard presentation, some programs find that a good form like this is sort of like an instructive roadmap that nurses in rural counties can follow, sort of a step-by-step approach to provide complete TB care. The form can detail what's expected in the patient information, diagnosis, treatment, management, and contact investigation. And I know that one program was clever in how they introduced the forms, and they commented that the nurses liked the way that the form guided their work. I think that must have been some very clever marketing, but it is true. These can be a great tool for keeping your case management on track. So if those of you out there who are case managers are thinking, what's in it for me? In fact, a form like this can really be a good guide step by step to getting things done correctly in TB control. Now, using a concise form like this can allow a program to review maybe 40 cases in 2.5 hours, just under 4 minutes a case. I think that you can do an uncomplicated extrapulmonary case maybe in 30 seconds, and a more complicated case may go 7, 8, or 10 minutes. But by managing your time, it's possible to be very efficient using an approach like this. And definitely, programs should remember to continue their practice of using periodic case reviews to make sure that the case and the contact information needed for this is being collected and that everything's being done right before the cohort review. The next step is presentation, actually, during the day of cohort review. And here is where information is presented on each case one by one. A typical location is in an office or a conference room or an auditorium if it's a face-to-face meeting. But more and more programs these days are also doing this by telephone or a web-based conference call, and that can be very effective. You want to keep the meetings to a manageable length, so I would recommend that you find ways of reviewing 20 to 50 cases at one sitting. So larger programs may need to do break up into regions and do more than one cohort review. For example, in New York City, each quarter they do 4 cohort reviews because they have 4 regions in the city. During the review, there is a chance to give feedback and actually teach about important points that are learned during the review. And it's important to analyze the outcomes. Nobody likes to think that they give a lot of information and nothing is done with it. And one of the principles of adult education is that the sooner the feedback is to the event, the better. And in fact, if you can analyze the outcomes right there during the meeting, and it's possible to do that with spreadsheets and PowerPoint presentations, you can give immediate feedback to people. Now, this is a sample form that comes from the booklet Understanding the TB Cohort Review Process instruction guide. And it's a sample where you just have one line for each patient, and then information about their TB diagnosis, the treatment, the disposition of the case, was it cured, still on treatment, lost, died, whatever. Contact investigation information is then on the right. So in a spreadsheet form like this, you can have, if you want, on the spreadsheet, an additional tab with all of the formulas to calculate the rates and indices. And this can be linked to a presentation that you can present for everyone to see. Now, the types of outcomes that you can get immediate feedback from are, was the patient cured? And you will have a measurable result, like the completion of treatment or other outcomes that you're looking at. In contact investigation, you can have measurable results like the number and % of contacts who were identified, tested, evaluated, started and completed treatment for LTBI. What's good is that all of this can be done pretty quickly, and it's feedback that people appreciate. The last step that really is what brings it full circle is to follow up in a timely manner on issues that get identified. Now, obviously the follow-up is different for different staff. Your supervisors, nurses, and case managers will be following up more on the case management suggestions that were made during the cohort review, making sure that patients and contacts finish their treatment. The TB program manager will probably be addressing programmatic concerns and concerns about modifying staff training or orientation to better meet the needs for staff to learn what they need to do the job. The data analyst or epidemiologist will be updating the registry, correcting any data errors or this, and preparing a summary report. And the medical reviewer will address the clinical issues that came up and especially provide medical consultation among the medical provider community if any is needed to make sure that treatments are going okay. As a result, over time the TB program can improve its outcomes through a continual cycle of implementing, evaluating, and refining the procedures and processes. This is really an example of continual quality improvement in action, and that's what makes it work. Just to summarize here, I'd like to show you how the information flows, because some people have had questions about that. The TB registry is where you get the list of patients, and that information goes to the cohort spreadsheet with one line for each patient. During the cohort review meeting, the forms that the presenters use contain the information which they present, and that goes to complement what is on the spreadsheet. Then, this one here is a manual spreadsheet, but you'd probably use a computerized one, and that would allow you to analyze the indicators, like the completion rate, death rate, default rate, the contacts who were identified, evaluated, started, completed, etc., and any reasons for stopping treatment. And after you've analyzed that, right there in the meeting, you can compare how you're doing to the national and local objectives and talk about what things are going well, what things aren't, and how you may be able to improve that. If you give immediate feedback to people, or later feedback, then everybody feels that they're involved in the process. And of course, reports are generated, and you follow up to make sure that you're doing what's needed to correct and improve any of the processes that you are working on. Benefits of the cohort review process are these. At the heart of it, it really can increase staff's accountability for patient outcomes. It's a case of the TB program doing something to make sure that each patient gets what they need to be taken care of with TB disease or latent TB infection. You can also improve your case management and identification of contacts, and programs that have started doing cohort reviews notice that within the first 6 months or a year or so. As far as motivating staff, it's important because a meeting like this can be a magnet. It can really draw people together to feel like a team that's working to fight TB. And for the leaders of the program, it can reveal your strengths and your weaknesses. And often things that you thought were doing well maybe are weaker. Other areas you thought were weak are actually real strengths, and you can give praise to a job well done. And it can help you figure out what staff training needs are and education needs are. So that concludes the summary of the process of cohort reviews. And now I'd like to turn the program over to Dawn Tuckey. As a CDC program consultant, she's had the good fortune to work with a number of programs that have adopted the cohort review process, and she's been a strong advocate for supporting the dissemination of this. Dawn?
Good afternoon. I'm briefly going to discuss the CDC's cohort review guidance and expectations. Okay, according to the 2010 TB Cooperative Agreement, it states that all TB programs receiving COAG funds should conduct cohort reviews as part of program evaluation activities. The language states that in order to improve TB case management and program accountability and feedback, that the grantees should hold quarterly cohort reviews at the state, the local levels, or both. Cohort reviews are integral to TB control and provide a systematic review of the management of cases and contact investigations. Instructions on the cohort reviews, definitions, roles of staff, timelines, core elements, and guidance on tailoring the process to your program are published in the CDC document, Understanding the TB Cohort Review Process Instructional Guide, and this can be found on the Internet. Grantees should report their progress on conducting cohort reviews, including the number of cases discussed, key issues identified during the reviews, and the recommendations made. And this should be included in your progress report, and it should be used in order to develop evaluation activities. Our expectations for 2010 are that all programs should conduct at least one cohort review by using one of the following approaches, whether it would be face-to-face, teleconferencing, or the hybrid approach. Regardless of whichever method that you choose, all models do consist of an interactive meeting to retrospectively review all TB cases that are registered in the program area in a given time frame. In addition, each model allows the delivery of concise and standardized presentations from the frontline staff to the program directors and clinicians. This allows for accountability and the immediate feedback and teaching and a systematic follow-up. Okay, the expectations for 2010 reporting requirements should be included in your interim and annual progress reports. The things that you actually should include are as follows. The date the cohort review occurred, the number of cases in each cohort, the type of cohort model that you used, whether it was a face-to-face telecommuting or whether it was a hybrid approach, the frequency of the cohorts, whether it was semi-annual or quarterly, and indication whether the cohort reviews included patients with disease or LTBI. The key issues that were discussed and the recommendations that were provided, and then the progress that on implementing these recommendations. Although the COAG states that each TB program should conduct cohort reviews on a quarterly basis, we acknowledge that certain programs may not need to do it this often, so therefore we are recommending to use the following to determine the frequency. Programs with 0 to 50 cases per year should conduct semi-annual cohort reviews. Programs with 50 or more cases quarterly. And for those low incident states with 15 cases or fewer, we're encouraging you to actually review the management of patients with LTBI or your contacts and their completion of treatment. And you can actually do this the exact same way as you would with the cohort review for active TB cases. Some of you may choose that you would actually want to do a regional cohort review, and that would be fine, and that's certainly acceptable. You can partner up with your neighbors. But if you do choose to actually do this, an agreement should be developed among all the partners and should include the process, the location, the model that you're going to use, and whatever each program's role and responsibility is in this. As I had stated earlier, with regards to understanding the TB cohort review process, the instructional guide published by CDC, this is certainly a document that is available for your use, and currently it's being revised, but that does not preclude you from actually using it to help you develop your process. It's basically going to have the new guidance that's in there and some other things, but certainly it's still a good document to use. As well, Bill had alluded to in the beginning that there are going to be other webinars coming up with regards to RTMCCs. The RTMCCs as well will be developing a standardized cohort review training. And I would also encourage you to work with your TB program consultant to establish a system that really works for your program. All this information that I actually have gone over here, plus additional information, can be found in the Dear Colleague letter that was sent out on August 9th, 2010. Thank you.
I would like to introduce now Dr. Kristen Kambili, a graduate of Fisk University who studied medicine at Columbia. He started working in New York City TB control 10 years ago and now leads the bureau there. He will share a historical perspective from a program that has been doing cohort reviews for a long time. Crispin?
Thank you, Bill. Hi, my name is Crispin Cambili. As Bill said, I'm the director of the Bureau of TB Control here in New York City. And I'll share with you a historical perspective of cohort reviews here in New York City, focusing on components, on how we do cohort review and why we like it, and challenges we've met along the way. So, many of you may be familiar with this slide. It shows the epic curve of TB cases in New York City spanning from 1978 to 1991. And I think this is representative of what was going on in many parts of the country at that time, when we saw a resurgence of tuberculosis after decades of decline in a number of cases of tuberculosis. A lot of things contributed to the resurgence, but one of the most important reasons was what we call the breakdown of the public health infrastructure. So that includes people, knowledge, and processes on how to control TB. And in New York City in 1991, there was so much TB that essentially every day you open a newspaper, the front page would be some story about tuberculosis. It was quite scary to be here to read the newspapers because there was twists and turns about how the stories were being told, but it was indeed a crisis. So one of the things that we noted at that time is that when we got better at collecting the information about just how much TB there was out there, because we couldn't really know the extent of the problem until we did good surveillance, and so one of the first things that was done was to collect adequate information as to how many cases were prevalent and how many cases were incident every year. And one of the telling problems was when one examined treatment completion. That is something that one wants to achieve at very high rates in order to have significant control over tuberculosis. We were hovering just under 50%. Under 50% of TB cases in New York City were completing their treatment, and that's a shame. And there weren't good data going back in the mid-'80s, but sort of going forward, we know what happened, and this is the problem that we saw. And one of the things that at that point, Dr. Thomas Frieden was appointed director of the TB program here, and one of the things that he was trying to do is how does one go about turning this tide of tuberculosis that we were seeing. And he invited to New York City an expert in tuberculosis in the name of Dr. Stiblo. Dr. Stiblo had been working at the International Union for a long time, and he had tried all sorts of things to the extent that, the concept of DOTS that we talk about today in global tuberculosis control is based on a lot of the things that he had done in very poor areas of the world. So he knew that one could leverage one's resources, both human and otherwise, to do very good control if one had a way of ensuring accountability and ensuring that one could actually answer the question that's posed in this slide. So when you identify your patients, you have good surveillance, you have all these patients in your log, in your register, what happens to them? That's where New York City found itself in around 1991. We couldn't really answer that question adequately. 50% of the time, yes, we could say, yes, we sort of know what happened to them, but the other 50%, we didn't know what had happened to those patients we had identified because they had disappeared into the concrete. So that's a picture of Dr. Stiblo, who came during a visit to the United States and to New York City, stated to Dr. Frieden, every patient you start on treatment, you're responsible for their outcome. And Dr. Frieden showed all these numbers of patients we had identified in New York City and said, yeah, I do see how many patients you diagnosed last year, but how many of them did you cure? And Dr. Frieden could only account for about half of them. So at that point, Dr. Stiblo introduced the concept of doing a cohort review as a way of ensuring accountability at every level. from the top of the organization of the TB program to the case manager that on a daily basis interacts with the individual patients and has information about those patients. So at that point, New York City set out to start cohort reviews, and they were in full swing by 1993. And the format in which they were used is the same format that we still use today. With technology, we've changed how things are presented, but the essence is still the same. The TB program director, I am that person now. I review every case that's been counted, and as Bill Bauer said, we do our cohort reviews about 6 months after the cases were counted. And in New York City, every case is assigned to a case manager. In some cases, the case manager is a nurse. In other cases, it's a trained layperson who is trained on TB 101 on other knowledge that is important for them to be able to case manage these cases. And these cases are presented to a group of people that includes the case managers, supervisors, managers that manage various units of the Bureau of Tuberculosis Control, clinicians that provide care in the public clinics here in New York City, and that also review cases that are being managed by non-public physicians. For example, we just finished a cycle of cohort reviews. We've divided the city up into 4 regions, and it took us about 3 to 4 hours for each cohort review, and the number of cases ranged from 26 to 62 for the first quarter of this year. It took us longer this time around because in September of this year we actually introduced a new TB registry. It's fancy. It has everything we ever wanted to be in our registry, so we were navigating through it. So it took us a little longer, but normally it takes us about maybe half that time, but we were able to still using a new system and go through the 62 cases in Queens, for example, in under 4 hours. So each case is presented and it's reviewed for all its tenets, both from a medical standpoint, social issues associated with it, as well as public health outcomes, including contact investigation. What this does is that we assure consistency with the principles of tuberculosis control, because tuberculosis control, we don't have to reinvent the wheel. Everybody knows what you need to do in order to have good outcomes. So we just make sure that what we're doing is consistent with what everybody else does. Everybody else recognizes as what one needs to do in order to have good control of tuberculosis. And then we also set standards for accountability. So presenting cases on a standard form helps everybody have the same kind of picture, so that when someone says something that seems to not be in line with what's expected, we all know, everybody recognizes that something is amiss. And, we follow up both the patients and their contacts, and that to us completes the picture of doing good TB control. And what we've done over the years is, instead of just having global indicators for our cohort, we have linked them to the national indicators. So our indicators at cohort actually are linked and aligned with the national TB indicators, NTIP indicators that the CDC has developed. So recently we revised our indicator collection process so that at cohort we see how well we're doing vis-a-vis NTIP indicators. So at cohort we know, for example, that at this point in time we have 80% of our patients demonstrate culture conversion, of course exceeding the benchmark that's been defined in NTIP. So we're trying to do that so that by the time that we report our numbers to the CDC, we already know how we're doing by following this through the cohort process. So this is a new addition, in addition to just identifying, for example, treatment completion. So with the advent of cohort in 1993, we did make tremendous inroads in terms of treatment completion for TB cases. And as you can see in the graph that's projected now on your screen, we managed to achieve treatment completion rates of close to 90%, starting from under 50%, because we demanded accountability at every level. And a lot of the reasons why people were not completing treatment is because there was no coordination between the treating physicians and the health department. And, things that treating physicians lacked, for example, to be able to follow patients, to track patients when they are lost. Those are skills that the health department in New York City had, and when the two of them got together and linked their efforts, the outcome was much better. So we've managed to achieve that, and we're able to make sure that this continues by doing the cohort review, where all these issues that might lead us back in time are identified and nipped in the bud, if you will. So I touched on a little bit on the evolution of cohort reviews. Initially, we focused almost entirely on treatment completion because we were so low, 40%, 50%. So the focus was on that. That was the biggest problem. Later on, we expanded and not only looked at the cases, but also looked at the identification, evaluation, and treatment of contacts for LTBI. And more recently, we've also focused on HIV testing, not only HIV testing of cases, but of contacts as well. Essentially, with the CDC's recommendation several years back that HIV testing be routinized, we latched onto that very strongly, to the extent that we have expanded HIV testing to contacts, and we demand that be addressed during cohort as well. For example, how many of your contacts had HIV testing? Anecdotally, we did an evaluation at one point looking at HIV infection rates among contacts whose index case is also HIV infected, and we saw a great number of HIV infection among the contacts, although they may not have been sexual contacts. But I guess because HIV is a family disease as well, maybe what we're seeing was a phenomenon in families, whereby 79% of TB contacts to HIV-infected index cases were also HIV-infected, compared to about 20% of contacts to people that didn't have HIV. So that was quite telling. It was a small group of contacts that we evaluated, but that sort of just strengthened our desire to be able to look not only at TB indicators, but also things that determine outcomes for TB, such as HIV infection. And as I said, this year we aligned our cohort indicators with CDC NTIP indicators to emphasize best practices. So benefits of the cohort for us, it's been the main way that we evaluate the things we're doing on a day-to-day basis. We ensure accountability. Everybody knows what they're supposed to be doing. It's improved greatly the quality of the data that we collect. And there's a forum where issues can be discussed with people that generally on a day-to-day basis don't come in contact with each other. And we use the forum also to praise staff for achievements. We try not to denigrate people. We try to chastise in private, but we try to praise people in public, and the cohort forum is one of those places we'd like to do that. Also, we highlight to our staff the overall strategic goals and objectives of the program, because maybe the case manager out there in Queens may not be on top of things in terms of knowing what is the organization's strategic goals, and we try to bring everything together so that people can see the big picture as to why they do the things that we ask them to do. So it has limitations. I said, we review our cases about 6 months out, and sometimes it's too late to make an intervention because the case may already have moved out of jurisdiction, or especially move out of the country. And as I said, it's time-consuming. We try to limit the depth of certain discussions because sometimes it takes us forever to complete these discussions. So one has to really learn how to manage their time, which I should be doing right about now. In conclusion, the good thing about cohort is customizable to content. The way we do it in New York is slightly different, and how they're doing it in Missouri, but it achieves the same goals. And it can be applied in various contexts of TB incidents. And actually can be applied to diseases beyond TB, and it's been used in Malawi when they started treating their HIV/AIDS patients with antiretrovirals in public hospitals. And it's been used in New York City in other areas, including the HIV program here uses it to track potential exposures when doing partner notification activities. And the Bureau of Tobacco Control was also going to adopt it, try to see how many people that have been modalities to help them stop smoking do actually stop smoking over time. So it can be used to areas beyond just TB control. And with that, I'll conclude that, this cohort has served us really well. A lot of people have come to visit us, and the thing that they quite impressed about is how we do cohort and how they can adopt cohort. I was on a visit to the United Kingdom, to London in September, and I was able to observe their first cohort that they adopted from what we do here in New York City. So it was quite, for me, very encouraging that, a lot of people find this useful and they've adopted it to their own environment. So thank you very much.
Now we will have Harvey Marks, who is the Chief of the Bureau of Communicable Disease Control and Prevention in the state of Missouri.
Okay, I'm Harvey Marks, and I'm going to be discussing Missouri's approach with the cohort review. Certainly reasons for implementation is it's currently in the CDC Cooperative Agreement. However, we had opted to implement this in 2005. We felt that it would be a good mechanism in evaluating our program. We've also seen that it has increased learning. As a low-incidence state, there are several jurisdictions that may not see a TB case for a while. We invite our partners to be part of the cohort, whether they have cases or not. And again, it's a good learning opportunity. We feel that it improves case management at both the state and the local levels. Again, mentioned that we use it as a tool to evaluate our program. And we've also found that it improved documentation in our clinic records, which certainly overall improves patient outcomes. Missouri's approach is that we look at TB cases that were identified over a 3-month period, and then approximately 6 months after those cases were identified, they are cohorted. We cohort our cases in a group setting. In the state of Missouri, we have a state health department, and then we have 114 autonomous local public health agencies. But we are able to connect to them through our network, and we actually have video conferencing available to those individuals. We have 5 district offices where they can come into to present the cohort, and a couple of our larger metro areas can actually directly connect into this teleconference. Again, as I mentioned, every LPHA is invited to attend, and again, we encourage those agencies that may be having a case coming up at the next cohort to kind of sit in, especially if they haven't seen a case in a while, to kind of get a feel of how the cohort runs here in Missouri. Also, the type of questions we're going to be asking and looking at. I've also got feedback from, the local agencies that it was a good review for them to be looking at things as they're working through and managing their case. We have adapted our TB registry where most of the cohort information that we're going to be asking can be obtained through that registry. And again, we look at individual outcomes as well as group outcomes. Again, Missouri tracks our progress toward our national and state and local program objectives. And as Bill had mentioned earlier, we have a form or process that we follow, so our presentations are consistent as we work through the process. A little bit on our registry. It has general patient information, medical treatment history, contact information. As I mentioned, the cohort form can actually be printed from WebServe or our TB registry, where somewhere between 85 and 90% of the information that would be covering is extractable through that registry. And again, we use the registry to generate our line listing, which we get out to our partners about 2 months before the review is actually scheduled. And again, this is just an example of our cohort schedule, is that the cases that were identified in January and March would be cohorting in the third quarter, July, September, April, June will be October, December, and so on. These are some examples of our state objectives that I mentioned earlier, that we like to have our cases interviewed within 3 business days of the case report. We like to see our contact investigations completed within 21 days. And all TB cases will be offered the opportunity to be screened for HIV. Every TB case in Missouri, even though, as I mentioned, there's state health department and then their partners at the local health agencies, each is assigned a case manager. We have written protocols that should be followed, and our department provides routine consultation, case management, and assists with extended contact investigations. We also provide, the cohort and, evaluation of the overall TB program in the state. Generally, with our cohort review, either the TB controller, which is myself, or our TB program manager, or our TB nurse consultant will be asking the questions through the cohort process. We may, depending on the length of the cohort, which in our state, which we have around 110 cases reported a year, and again, about a quarter of those are done at each cohort, we may switch up where give one of the persons listed above a break. But again, we don't want to be bombarding the presenter with different questions. So again, we try to limit it to our TB controller, manager, or nurse. Again, we're looking at, treatment information. Did they begin on the 4 drugs? Was it appropriate? HIV status. Were negative labs obtained? Sometimes, you focus on, positive results, but, looking at sputum conversions, culture conversions, were those documented in the records? And then, of course, successful completion of treatment. On the contact investigations, as mentioned earlier, we're looking at number of contacts identified, who are appropriate for testing, where the evaluate started, and completion of treatment, not only for LTBI, but those who were identified with disease. Did we get those individuals within the system? During the cohort review, we also, even though we try to prepare ahead of time, due to different reasons, there may be missing data as the cohort is progressing. But as the cases are presented, a lot of our case managers bring their files, and they're able to provide us with missing data that we did not have. We may have opportunity to update incorrect data. There may have been some information initially that was misrepresented that we can correct. Certainly, we're looking at the DOT coverage, the timeliness of our investigations, and how we're meeting our objectives. The contacts, we're looking at, for those who started treatment, how many of those, did they refuse? Were they having adverse reactions, moved, died, etc.? So we're also looking at the contacts. And samples of issues that we have had during the cohort is, again, I mentioned earlier, documentation of culture conversion. This is one of the things that we had identified early on when we first initiated the cohort in 2005, is, again, documenting those negative results and making sure that we have those, that we're offering HIV status, or we have HIV status on all of our TB disease, and how well are we doing on our contact investigation and follow-up. We feel here in Missouri it's an important meeting of our TB program and our partners within our state. It's low-tech, and it could be done by hand, but as we say, we've integrated it into our TB registry where most of it can be extracted. Our cohort process is closely linked to CDC and our state objectives through our cooperative agreement. It's a group process. You know, everyone leaves the meeting knowing the results are soon afterwards. As with most technical systems, you know, we may have some glitches in our web connection and stuff, and we may have to present our data up on our intranet site with our partners, but if we can't present it at the end of the cohort, we get an email out to all of our partners saying that the data is now available and is up there for review. So not only the state, but our partners know how well we're reaching and obtaining our objectives in our grant and the objectives that we've set for ourselves. It's a teaching and learning opportunity. Again, we have partners out there that have vast amount of experience dealing with tuberculosis. I'm sure, as many of you are aware, there can be turnover at the local agencies, and even for those that don't have turnover in a low-incident state such as Missouri, it may have been 4 or 5 years since a jurisdiction had a case, and the opportunity for them to come to the cohort and sit and kind of look at the key components of a case management contact investigation, I think has proven very valuable. And that pretty much concludes our presentation.
Okay, hello, I'm Heidi from Oregon, and I'm going to talk about our TB cohort review here. So just a little bit about TB in Oregon. We are a low-incidence state, and we have a large geographic area. Our metro Portland area is about 2.5 million, but we also have what's called frontier areas, where we have very large counties, and there's usually only about 1,000 people in those counties. In 2010, we had 89 cases, and 72% were foreign-born. Our state TB control staff consists of just 3 people, myself as the TB controller. We also have a TB epidemiologist and a TB registrar. So some of our challenges overall are staffing, keeping expertise in TB in our rural counties, cultural competency, since we do have a large percent of foreign-born patients, and DOT, especially in our rural areas. So this is just a little timeline of how our cohort review started. We were really fortunate that way back in 2007, our metro area county, Multnomah, really started having cohort reviews. They called them the end of treatment review, but the concept was the same. So they really were the innovators in the state, and we're fortunate for that. Then in July of 2007, they invited the other 2 metro counties to join them, and they had a face-to-face review with those 2 other counties. Then in January of 2008, our program, Oregon TB Control, started a cohort review for the balance of the state, the non-metro counties, and we were doing that by phone. Then finally, in April of 2009, we combined the cohort reviews with the metro area and the rural areas. So that has been outstanding, and that took a bit of an effort on our part. And then finally, in June of 2010, the state wrote a program element which basically requires cohort review participation of all of our counties in order for them to receive funding from us. So just to conclude on that, establishing cohort review takes time, and I think that that is okay, and just to understand as you get started that it is a process. So this is a little bit about how we prep for the review. We do a quarterly review, and we review cases that were counted 6 to 9 months prior. Our TB epidemiologist pre-fills a form with the case and contact information before the review, and she emails it to the TB nurse case manager. Now, I have to say this is a lot of work on our TB epi's part, but it's really worth it because it helps save the nurses time. And it also helps the TB epidemiologist to gather all the data before the review. And I think that helps the TB nurse case managers feel a little bit more ready for the review, and there aren't any surprises for them that occur as the review is going on. Then finally, once our TB epidemiologist has all that information gathered, she emails all the counties in our state the completed form, so if they want to listen into the review, they can follow along with the cases. So this is a little bit about our participation. The TB nurse case manager for the county is required to present. We do allow somebody else to fill in if they can't make it. Sometimes counties will actually do a joint presentation if the patient is transferred, and that's kind of fun. Also, I always participate as the state TB controller. Our TB epi participates. The metro area TB nurse supervisors participate, and we always have a TB physician attend. All the other health officers for the state and all the other TB nurse case managers are invited to attend, and they can call in at any time if they wish. Other attendees we sometimes have are medical residents, MPH interns, and sometimes we actually have some TB nurse case managers from Washington State. And our last review, we had the lab participate as well, which was really great. And we allow questions from any participant and actually encourage that. So on the day of the review, our review is about 3 hours. Our TB epidemiologist presents aggregate data on the cases and their contacts for the quarter under review. And she kind of comments on how the data looks in comparison to the program objectives and the national objectives. The TB nurse case managers attend in person. Other areas attend via teleconference. Everybody has those sheets that we emailed out previously so they can follow along with the case details. Some of the initial barriers that we encountered when we first started to do these reviews was really a fear of presenting on the part of the nurses. Some people said they didn't have enough time to participate. And then, like as I alluded to earlier, we had some difficulty combining the reviews and also some problems with sound quality. So I'm going to address these issues as I go on. So one of the things we did to kind of overcome some of these barriers, especially the fear of presenting, is we try to encourage a more casual atmosphere. During the review, we have food. It's kind of mellow and casual. We also allow the nurse case managers to put in some individuality when they do the review. Sometimes they'll add pictures. For example, the one you see here is some pills wrapped in cotton candy that one of the nurses used to get a kid to take some medications. Or sometimes they'll put in a chest x-ray if it's unusual. Also, we pre-fill the forms, and that has really saved nurses time, and they appreciate that. We also minimized some of the routine clinical data on the form, so it didn't seem so repetitive. And we added a few subjective questions to create some more discussion. So nurses will discuss what incentives and enablers they used, what unique case management strategies they utilized, any community resources they used. And then most importantly, I think, is anything you would do differently the next time you got a similar case. So I think this is kind of some of our proof of success. People call in when they don't have to, and I think that's great. So we have lots of our counties that call in just because they want to listen and learn. So I think that shows how valuable it is to them. We have seen that our HIV testing has improved. We're definitely getting more HIV tests done. I think overall DOT is better managed, and a big part of that is during the review, nurses will share strategies on how they got DOT done. For example, some of them will use a local pharmacy, or we've even had fire departments utilize, and that's really helpful, especially for the rural areas. Also, we learn from each other and we gain additional resources, and so nurses don't always feel like they have to rely on the state for consultation. At times they'll call each other, and that's really great. So we're still trying to improve, and I think we always will be trying to improve. It still seems a little too long at times, and we're trying to narrow it down to really what is essential and most beneficial for our listeners. Sometimes we still have sound quality issues, and our remote listeners will report that they're not hearing everything. We did buy a new Polycom that has microphones that can be handed around the room, and I think that's helped. Rural counties at times have expressed concern for their rural patients regarding confidentiality, and that's an interesting issue. If we have a very rural county, sometimes, if you are talking about a Hispanic patient who's a male, that could easily identify that person in the community. So we have to be very careful, especially for our rural patients. We need to work a little bit further on a process for follow-up after the review, and we're still tackling that. I was going to spend a couple seconds talking about evaluation. Right now, the cohort review is not part of our formal evaluation process. However, as I mentioned earlier, we do compare our quarterly data to national objectives. So we do evaluation that way. And it has really been useful to improve contact follow-up and also in HIV testing. And it's also helpful as far as evaluation goes in ensuring that everybody's using the same data definitions. For example, what is directly observed therapy versus self-administered therapy. So that has been very helpful to us as well. So that is my presentation, and thank you for your time.
We now have some time for discussion.
First question comes from the line of Richard Kohler.
My question is, do you have separate processes in Missouri, New York, and Oregon for prospectively troubleshooting, in addition to the cohort process?
Either member of our panel who presented their programs should answer this question. And I do think that the programs continue their prospective work in addition to preparing for cohort.
Yes, this is Missouri, and I would say that we request certain elements from the record to be returned to the state, and our nurse consultant does, review case information through the process. So, we do not just rely on the cohort review process.
And this is Heidi from Oregon. I think similarly, we do require that the counties send in a case report form, and then usually, since we're small enough, I'll go through the case report form and look at drug dosages and things like that. And if the county is a small, lower incidence county, we'll call them and follow up as the case is being treated.
Hi, this is Kristen from New York. Yes, of course we do. When a case is reported to us, and for example, if the case is potentially very infectious, a smear positive case, a case manager is assigned is supposed to interview that case in under 3 days. And from that point on, when we have engaged the patient, there is a series of weekly case management meetings in the regions that I described previously. And it is at these weekly case management meetings where the case manager gets guidance from their immediate supervisors on how to address issues that might be identified. Sometimes, a case may fall through the cracks and not undergo that process, and these are the cases that eventually bring in issues at the cohort 6 months later. But yes, we do have a monitoring, ongoing, weekly management case meetings so that issues can be identified promptly and addressed right away.
Thank you.
Next question comes from the line of Clayton Weiss.
I had 2 questions. First question is, why review patients who are at the end or near the end of their treatment and rather than reviewing patients in the middle of their treatment? And the second question is, what is a hybrid approach? Thank you.
This is Bill Bauer. I'll go ahead and start the answer on this one. Of course, during your normal case reviews that you do perhaps at month 2 or month 4 during treatment, you do review those cases, and that part of your routine case management should continue. The purpose of cohort review is to look at things later and see really what the outcomes have been. The second question was, what is a hybrid approach? And a hybrid means that, I'll give you the example of the state of Washington. Most of their cases are in, not most, the largest number are in Seattle and Kings County. So they do a face-to-face cohort review in the morning with those cases. And then in the afternoon, they divide the state into 2 regions, and they'll do, say, the northern region by phone for an hour or so, and then the southern region by phone for an hour or so. So it's hybrid in the sense that they're doing a face-to-face meeting followed by 2 regional telephone-based cohort reviews. And that's probably going to be a good approach in many more extensive states where you are, have 1 or 2 cities where TB is concentrated, but a larger area where you can't expect people to come to a meeting from. If anyone else would like to comment from the panel, please do.
Yes, Bill, this is Harvey, and I would also like to add that, looking closer to the end, looking to see what outcomes were met or not met, in our state, in that we have the autonomous local public health agencies that partner with us, it allows them an opportunity to see as a state how we are meeting those objectives and national goals as well, and how just 1 or 2 cases can impact, since we are a low incidence state, those outcomes that we report nationally.
Hi, this is Crispin. I guess Bill did mention this because we're looking at outcomes, and for TB, the most important outcome is treatment completion and cure. So that doesn't take place until much later. So it does help to wait a little while in order to give time to the case managers and their supervisors to address the issues that come in day to day. And remember also, there are contacts to be identified, to be evaluated, and perhaps to be placed on treatment. And if you add all that together, those are issues that take a while to to come around to wrap one's head around, and so it does make sense to do these cohort reviews at the time that we do them. So yeah, just to reiterate, they're not supposed to be the only way that one looks at their cases. One is supposed to have an ongoing monitoring process that is much more regular than the cohort.
This is Heidi from Oregon. I just wanted to mention about the hybrid approach. So we have kind of a combined metro area and rural area review. And I just wanted to mention that our more rural areas have really seen the value in at least being able to listen in to the metro area review because they gain a lot of knowledge from that.
Next question comes from the line of Allison Mayuri.
This is Regina Gore, program consultant in Atlanta, and I have a question. I have an area that does not have the luxury of having a medical consultant or a TB epi or data analysis person, and has gone so far as to do cohorts with another area. So my question is, how can they provide analysis back to their area when they don't have a medical consultant or a TB epi? And, what would they provide as follow-up for the review? Because the information that they're getting is coming from another doctor in another state who has, consented to being on the call as a medical consultant for another area. But because this is a very small area with limited staff, this is the best way that they have found to come up with doing cohort review.
Hi, this is Bill. I would suggest that most of the follow-up actions need to be done by that program itself and not be provided to them, but that guidance about what needs to be done is what comes from the cohort review. And so a lot of the follow-up is in correct data collection or follow-up in contact investigation, perhaps in training. And I think that the local program can probably do a lot of that by themselves. I wonder whether a public health student or somebody could be found who can give some help in the epidemiology area in analyzing data for them. That might be another possibility. But I'd like to hear from the other presenters, too.
This is Heidi from Oregon. We do have a TB epidemiologist, so that's really great. But I don't think the analysis needs to be extremely complex. So, maybe somebody else could be trained to do it.
Thank you. Okay, well, it's really fun for me to see how programs that have started doing it recently or been doing it for a decade or more or anywhere in between are using the same principles, and also how they can do it by telemedicine hookup or by phone conference call or just old-fashioned face-to-face meetings. Either way works. I really want to thank our faculty for sharing their knowledge and experience with us. Thank you very much for your participation. This concludes the webinar today on the introduction to the TB cohort review process.